Okay, quick pop quiz before we even start, and I promise this is the only quiz all video. If your eyes and mouth feel like the Sahara Desert decided to move in permanently, do you automatically have Sjögren's? Buzzer sound. Wrong. And apparently a lot of doctors are noticing patients, and honestly, a lot of other doctors, making that exact same wrong guess, over and over, which is why rheumatologists have started quietly waving a flag that says, in essence, hang on, we need to talk about this. So let's talk about it. If you keep leaving appointments remembering symptoms you forgot to mention, I made a Sjögren's symptom map to help you track the full pattern. Comment symptom map, and I'll send it to you. Here's the plot twist hiding in plain sight. Dry eyes and dry mouth is not a diagnosis. It's a description. It's like walking into a doctor's office and saying I have a pain, and the doctor going cool, where, why, and caused by what, because pain could mean anything from a paper cut to a broken femur. Dryness of the eyes and mouth has an actual medical umbrella term for it, and that term is Sicca. Sicca just means dry. That's it. That's the whole definition. Sicca is the symptom. Sjögren's is one specific, autoimmune reason you might have that symptom, and here's the part that should stop you mid-scroll, it is nowhere close to the only reason. And I want to sit with that for one more second before we move on, because this is genuinely the entire video in a single sentence, and everything after this point is just proving it to you with receipts. Somewhere along the way, in doctors' offices, in Facebook support groups, in casual conversations between patients comparing notes, dry eyes and dry mouth quietly got shortcut into must be Sjögren's, as if it were the only door those two symptoms could possibly walk through. It isn't. It's one door out of several, and picking the wrong one has actual consequences, which we are going to get into in detail. But first, let's build the mental model properly, because once this clicks, you'll never unclick it. Think of it like this: check engine light is the Sicca. It's just a light on the dashboard telling you something's off. Sjögren's is one specific mechanics diagnosis for why that light came on. In this case, your immune system's white blood cells storming the gates of your tear and salivary glands like they personally owe it money, and physically destroying the tissue that makes moisture. But that same check engine light can come on for a dozen other reasons that have nothing to do with your immune system attacking anything at all. And that mix-up, the light is on, must be that one specific cause, is exactly the mistake doctors are worried is happening constantly, in exam rooms, right now. Let's push the analogy one step further, because I think it's actually the clearest way to hold this in your head long term. Imagine dryness is a locked door, and there are several completely different keys that can open it. One key is Sjögren's, the autoimmune key, immune cells literally invading and destroying the glands from the inside. Another key is medication side effects, a huge list of extremely common drugs, from certain blood pressure medications to antihistamines to antidepressants, that can dry you out as a side effect with zero autoimmune involvement whatsoever. Another key is straightforward aging, since gland function does gradually decline over a lifetime in everyone, Sjögren's or not. Another key is a completely different disease altogether, like the fibrotic, non-inflammatory gland damage we are about to see in scleroderma. Same locked door. Wildly different keys. And here's the kicker: only a biopsy and specific blood work can actually tell you which key you're holding. You cannot tell by the door alone. The door looks identical no matter which key opens it. If your mind just went, wait, I've been assuming a key I never actually confirmed, type curious in the comments. That's exactly the reaction this whole video is designed to spark, and I want to know how many of you just had it. Let's make this real instead of abstract, because a couple of composite patients make this click instantly. Meet Jenna. Jenna has scleroderma, a separate autoimmune connective tissue disease that causes skin and tissue thickening. About 5 years into her scleroderma, her eyes and mouth started drying out. Reasonable assumption, right? Autoimmune disease, dry eyes, dry mouth, must be Sjögren's, case closed, roll credits. Except when her doctor actually ran the real diagnostic tests, the ones that check for actual immune cell invasion of the glands, they came back negative. Jenna's dryness wasn't caused by her immune system attacking moisture-producing glands at all. It was caused by fibrotic scarring, literally, tissue in the gland stiffening and losing function the same way scleroderma stiffens skin elsewhere in the body. Same symptom. Completely different mechanism. Not Sjögren's. Now meet Priya. Also has scleroderma. Also developed dry eyes and dry mouth years into her disease. Looks identical to Jenna from the outside. Same complaint, same timeline, same why is my mouth always dry energy. But when Priya got the same battery of tests, the antibody came back positive. The gland biopsy showed actual lymphocytes, immune cells, swarming and destroying glandular tissue. That's true Sjögren's. Same starting symptom as Jenna. Completely different disease underneath it. And just to round this out with one more angle, because the mix-up doesn't only happen in scleroderma patients, meet Marcus. Marcus doesn't have any other autoimmune disease at all. He's in his late 40s, previously healthy, and started noticing dry eyes about 2 years ago. He assumed it was just screen time, he's on computers all day for work, and figured it would sort itself out with some over-the-counter drops. It didn't. When he finally brought it up at a routine physical, his doctor ran a quick checklist. How long has this been going on? Any dry mouth too? Any joint pain? Any unusual fatigue? Turned out yes to all of it. He just never connected the dots because each symptom showed up gradually and separately over 2 years, not all at once in one dramatic moment. His blood work came back positive for the SSA antibody, and a follow-up lip biopsy confirmed lymphocytic infiltration. Marcus had primary Sjögren's, meaning it showed up entirely on its own, no scleroderma, no lupus, nothing else attached to it, and he'd been quietly living with an undiagnosed autoimmune disease for 2 years because dry eyes felt too minor and too vague to bring up as its own standalone problem. 3 people. 3 totally different outcomes hiding under what sounds, on paper, like the exact same 2-word complaint: dry eyes, dry mouth. If Marcus's story hit close to home, 2 years of quietly assuming it was just screen time, type seen in the comments. That 2-year gap is more common than you'd think, and I want anyone in that exact spot right now to know they're not the only one. And here's the number that should genuinely surprise you. In patients with scleroderma who report dry eyes or dry mouth, researchers have found that only around 1 in 5, some studies land closer to 14%, others closer to 21%, actually turn out to have true, biopsy-confirmed Sjögren's. The rest, the clear majority, have Sicca from something else entirely: fibrotic changes, medication side effects, or other non-inflammatory causes. Read that again. Most of the dryness in this specific patient population isn't Sjögren's at all. It just looks exactly the same from the patient's side of the exam table. Let that number sit for a second, because I think it's the single most underappreciated fact in this entire conversation. If you have a connective tissue disease and you're dry, the math genuinely says you're more likely to be a Jenna than a Priya. That's not a reason to relax and assume you're fine. Plenty of people are exactly like Priya, and the only way to know which one you are is testing, not guessing. It's a reason to actually get tested instead of accepting an assumption dressed up as a diagnosis. Okay, so if it looks identical, feels identical, and complains about lemonade the same way, how on earth do doctors actually tell these apart? Great segue, because that's exactly where this gets fun, in a slightly nerdy, slightly detective show kind of way. Think of this next stretch as the forensics lab portion of our investigation. First tool, the Schirmer test. Doctors tuck a tiny strip of filter paper into the corner of your eye for about 5 minutes, and measure how far your tears travel up the paper. Less than 5 millimeters in 5 minutes counts as clinically dry. Simple, cheap, a little annoying, tells you almost nothing about the cause though, because both Jenna's non-Sjögren's dryness and Priya's true Sjögren's dryness can post the exact same disappointing number on this test. It confirms dryness exists. It does not tell you why. Second tool, and this one's honestly a little dramatic for how simple it sounds, staining the surface of the eye itself. Doctors use special dyes, one called fluorescein, which shows up as a bright apple green under the right light, and another called lissamine green, which highlights the white of the eye, to reveal tiny areas of damage on the eye's surface that are otherwise completely invisible to the naked eye. Every time a chronically dry eye blinks, it can actually scrape away microscopic pieces of the eye's surface tissue, the same way windshield wipers running dry on a dusty windshield leave tiny scratches instead of just clearing water. Under the dye, doctors can literally count these little damage points, and score how severe the surface wear is. A handful of dots is mild, a dense scattering is severe. Again, this confirms real physical damage is happening. It still doesn't tell you the underlying cause. Third tool, the spit in a tube test, which is exactly as glamorous as it sounds. Patients spit into a collection tube for a set number of minutes, and doctors measure the volume. Less than half a milliliter in 5 minutes signals meaningfully reduced saliva flow. There's also a fancier cousin of this test called a salivary scintigram, where a tiny, safe tracer dose gets absorbed by your salivary glands, and doctors track how quickly the glands take it up and then release it after you're given something sour like lemon juice to stimulate flow. In a healthy gland, that tracer floods out fast once stimulated. In a badly damaged gland, it barely moves at all. Useful for seeing how much functional tissue is left, still doesn't crack the case on cause. There's also an imaging option that's become more popular recently: ultrasound of the salivary glands themselves. A normal gland looks smooth and even on ultrasound. A gland under sustained autoimmune attack starts to look mottled and cratered. Genuinely, doctors describe it as looking like the surface of the moon, as healthy tissue gets replaced by patches of damage. It's non-invasive, doesn't involve needles, and is increasingly used as a supporting piece of evidence alongside the other tests, though on its own it still doesn't replace a biopsy for a definitive answer. Fourth tool, and this is where it gets genuinely interesting: the lip biopsy, checking what's called a focus score. Doctors take a small tissue sample from minor salivary glands inside your lower lip and look under a microscope for clusters of lymphocytes, immune cells, physically infiltrating and destroying the gland structure. A normal gland looks open and spacious under the microscope, mostly just tissue doing its job. A true Sjögren's gland looks like immune cells crashed the party and started demolishing the furniture, dense clumps of them, visibly replacing what used to be functional glandular tissue. This is one of the most direct ways to actually see the autoimmune attack happening, rather than just inferring it from a symptom. It's a small, quick procedure, and yes, it's a little uncomfortable, but it's genuinely one of the most decisive pieces of evidence in the entire workup. If you've never even heard of a lip biopsy for dry eyes before this video, type "didn't know" in the comments. This is exactly the kind of test that should be common knowledge and just isn't yet. Fifth tool, an antibody blood test called SSA, sometimes still called Rho. Here's the plot twist inside the plot twist. SSA antibody is, and I mean this as a compliment to its chaos energy, extremely promiscuous. It shows up in true Sjögren's, sure, but it also shows up in lupus, in some cases of scleroderma without Sjögren's, and even in some otherwise perfectly healthy people who will never develop any autoimmune disease at all. So a positive SSA test alone isn't a MIC drop diagnosis. It's one clue in a case that needs the biopsy and the clinical picture to actually close. There's a related antibody, SSB, that used to get tested alongside SSA, but more recent analysis has found it doesn't really add much independent diagnostic value once SSA is already accounted for, which is a good example of how even the testing itself gets refined over time as more data comes in. And that's exactly why rheumatology built an actual point-based scoring system for this: the American College of Rheumatology's classification criteria. Positive lip biopsy, positive SSA antibody, dry eye staining, and the Schirmer and saliva flow tests each contribute points, and once you cross a specific point threshold, doctors can say with around 90% confidence, yes, this is genuinely Sjögren's, not just Sicca wearing a Sjögren's costume for Halloween. It's not a vibe check. It's an actual, weighted, evidence-based scoring system, built specifically because the patient reports dry eyes and dry mouth was never supposed to be sufficient on its own. So here's the part that turns this from fun medical trivia into actually, genuinely, get this checked out important. And it's the whole reason doctors are raising the alarm on the mix-up in the first place. The label changes what happens next, in ways that materially affect your health. If your dryness is true Sjögren's, the autoimmune, glands under attack version, that opens the door to a completely different management path. Immunosuppressive and immune-modulating treatments become genuinely relevant options, because there's an actual overactive immune process to calm down. Rheumatology guidelines generally build this out as a kind of ladder. Hydroxychloroquine, the same medication used in lupus, is often a reasonable first step for joint pain and general symptom control. If that's not enough, methotrexate sometimes gets added on top. Short courses of steroids can help knock down a flare, though long-term steroid use gets avoided where possible because of its own downsides. For more stubborn or severe cases, other options like leflunomide or sulfasalazine can come into play, largely borrowed from the rheumatoid arthritis playbook since the joint involvement overlaps. And for the dryness itself, specifically, there are dedicated medications. Pilocarpine and cevimeline are the two big names, that stimulate whatever functional gland tissue you have left to actually produce more moisture, which only makes sense to prescribe once you know there's genuine gland tissue worth stimulating in the first place, rather than fibrotic tissue that stopped listening entirely. It also means your medical team should be watching for a specific, documented list of extraglandular complications, joint pain, peripheral neuropathy, lung involvement, kidney involvement, and yes, an elevated risk of lymphoma, which some research puts at around 5 to 10% lifetime risk in confirmed Sjögren's patients specifically. That's not a small footnote. That's the entire reason regular monitoring matters once you have the correct label. A confirmed Sjögren's diagnosis should come with periodic blood work checking things like blood counts and complement levels, regular attention to any new lump or swelling in the salivary glands, and a genuinely lower threshold for biopsying anything that looks even slightly suspicious, precisely because of that elevated risk. But if your dryness is Sicca from a non-Sjögren's cause, like Jenner's fibrotic gland changes, pumping your immune system full of immunosuppressants doesn't address the actual mechanism, because there's no overactive immune attack to suppress in the first place. You'd be taking on real medication risk, increased infection risk, organ monitoring requirements, the whole list of things that come with immunosuppression, for a treatment aimed at the wrong target entirely. Management instead focuses on the dryness itself, artificial tears, saliva substitutes, dental protection, moisture-retaining goggles for severe eye cases, without chasing an autoimmune process that was never actually there. That's the stakes. In one sentence, get the label wrong, and you can end up either undertreated for a real autoimmune disease quietly doing damage in the background, or overtreated with immune-suppressing medication for a problem that was never immune-related to begin with. Neither direction is great. Both are avoidable with the right tests. If this is the first time anyone's laid out why the label actually matters, not just as a technicality, but as the thing steering your entire treatment plan, type answers in the comments. That's what getting this right actually buys you. And I want to spend a minute on something that gets almost no airtime in this conversation, but genuinely should: the psychological weight of getting this wrong, in either direction. Living with unexplained, unlabeled dryness for years, because nobody ran the right tests, or because a wrong label got casually applied and stuck, carries a real emotional cost, separate from the physical symptoms entirely. Research on quality of life in Sicca and Sjögren's patients has found meaningfully elevated rates of sleep disturbance, anxiety, and depressive symptoms compared to the general population, and a huge overlap with fibromyalgia, which brings its own layer of chronic pain and fatigue into an already complicated picture. Even people with what gets labeled as mild dryness report real interference with daily activities, social interactions, concentration, and intimacy. This isn't a minor inconvenience being treated like a big deal for dramatic effect. It's a genuinely disruptive set of symptoms that deserves an accurate name attached to it, partly because an accurate name is what actually unlocks the right treatment, and partly because there's something real and valuable in simply knowing what you're dealing with, instead of living inside a medical question mark for years at a time. If you've ever had a doctor, a friend, or even your own inner voice tell you that dryness and fatigue were no big deal, type valid in the comments. What you've been carrying is real, and it deserves to be treated like it. Before we get to the myths, let's take a quick side quest through the rest of that locked door, many keys list, because I promised earlier we'd come back to it, and I think it's genuinely one of the most useful parts of this entire video for anyone watching who doesn't have a diagnosed autoimmune disease at all. Medications are, by a wide margin, one of the most common and most overlooked causes of Sicca that has nothing to do with any autoimmune process whatsoever. The list of drugs that can dry you out as a side effect is honestly a little absurd once you actually see it laid out. Certain blood pressure medications. Common antihistamines, the same ones you might grab for seasonal allergies. Antidepressants across several different classes. Certain stomach acid medications. Diuretics. Even some anti-anxiety medications. None of these are attacking your glands the way an autoimmune process would. They are just chemically interfering with the signals that tell your glands to produce moisture in the first place, and once you stop or switch the medication, in many cases, the dryness improves right along with it. This is exactly why a good workup for Sicca should always start with a careful review of your current medication list before jumping to any bigger diagnostic conclusion. Then there's the simply mundane stuff. Dehydration. Excessive screen time, since staring at a screen measurably reduces your blink rate, and blinking is what spreads moisture across your eyes in the first place. Mouth breathing, especially overnight, which dries out the mouth independent of any gland dysfunction at all. Smoking, diabetes. Even something as ordinary as sleep apnea can contribute to nighttime dryness. None of these require an autoimmune explanation. They require a mirror, a water bottle, and sometimes a conversation with a sleep specialist. It's genuinely worth pausing here and doing a quick honest inventory of your own habits before assuming the worst-case autoimmune explanation, not because autoimmune disease isn't real or worth investigating, but because ruling out the boring, fixable stuff first is exactly how good diagnostic medicine is supposed to work, layer by layer, cheapest and simplest explanation first. And then there's a whole category of other, rarer non-Sjögren's causes worth at least naming. Prior radiation treatment to the head or neck for an unrelated cancer, which can permanently damage gland tissue through an entirely mechanical, non-immune process. Sarcoidosis, a different inflammatory condition that can also infiltrate glandular tissue. Even something like advanced Parkinson's disease can affect the nerve signals controlling saliva production. Cystic fibrosis, certain viral infections, and hormonal shifts around pregnancy or menopause round out an already long list of legitimate, non-autoimmune explanations that a careful doctor should be weighing right alongside Sjögren's, not after it. The point of this whole side quest isn't to overwhelm you with possibilities. It's to hammer home, one more time, from a completely different angle, that dry eyes and dry mouth genuinely is just a symptom with a long list of possible explanations sitting behind it, and Sjögren's, while important and absolutely worth ruling in or out properly, is one name on a much longer list, not a default assumption. If any of those boring causes, a medication, dehydration, screen time, just made you go oh, that might actually be me, type worth checking in the comments. Sometimes the fix really is that simple, and it's worth ruling out before anything else. Okay. Myth-busting time, because I can already feel some of you reaching for the wrong conclusion. Actually, hold on, before the myths, I want to answer the question that's probably nagging at some of you by now. If the tests exist, if the criteria exist, if the whole point-based scoring system exists, why does this mix-up keep happening at all? Shouldn't this be a solved problem? Part of it is just how modern medicine is structured. Dry eyes usually get you an appointment with an eye doctor first. Dry mouth usually gets you a dentist raising an eyebrow at your latest round of cavities. Neither of those specialists is necessarily positioned, or even trained, to run a rheumatologic antibody panel or order a lip biopsy. That's squarely rheumatology's job, and rheumatology often only enters the picture after a referral, sometimes years into the symptom timeline. So there's a structural lag baked into the system before the right specialist with the right tools even gets involved. Part of it is the sheer overlap in how these conditions present. Fatigue, joint aches, dryness, brain fog. These symptoms show up in Sjögren's, sure, but they also show up in fibromyalgia, in general aging, in depression, in a dozen other conditions that have nothing to do with autoimmune gland destruction. A doctor seeing a patient with this exact cluster of vague, overlapping complaints has a genuinely hard diagnostic puzzle in front of them, not a lazy one they're failing to solve. And part of it, honestly, is momentum. Once a patient with an existing autoimmune disease like scleroderma or lupus starts complaining of dryness, well, you probably have Sjögren's too, is such a fast, easy, plausible-sounding explanation that it can get written into a chart, repeated at follow-up visits, and never formally tested, simply because it never gets actively challenged. Nobody's being careless on purpose. It's just how assumptions quietly calcify into treated as fact status in busy, real-world medical practice, appointment after short appointment. None of this is meant as a takedown of doctors, genuinely. It's meant to explain why the burden of asking the specific question, have we actually confirmed this with a biopsy and antibody panel, or are we working off an assumption, often ends up falling on the patient. Not because doctors don't care, but because you're the one person guaranteed to be present for every single piece of your own medical story, across every specialist, every referral, every appointment, in a way that no individual doctor along that chain necessarily is. If you've ever felt like you were the only one connecting the dots across your own doctors, type advocate in the comments. That instinct you've had this whole time? It was right. Okay, now let's actually get to the myths. Myth: if my eyes and mouth are dry and I have another autoimmune disease, I must have Sjögren's too. Reality: as we just walked through with Jenna and Priya, that assumption is wrong more often than it's right in conditions like scleroderma. Dryness needs its own dedicated workup, the biopsy, the antibody test, the actual diagnostic criteria, not just a, well, you already have one autoimmune thing, may as well have two. Myth: a positive SSA blood test means I definitely have Sjögren's. Reality: remember, SSA is promiscuous. It shows up in lupus, sometimes in scleroderma without Sjögren's, and even in some healthy people. A positive SSA is a clue that needs backup, not a verdict on its own. Myth: if the Schirmer test says I'm dry, that proves what's causing it. Reality: the Schirmer test and the spit-in-a-tube test are excellent at confirming that dryness exists. They are completely silent on why. That's the biopsy and the antibody test's job. Myth: Sjögren's is a rare disease, so it's statistically unlikely to be me. Reality: it's actually one of the more common systemic autoimmune diseases out there, estimated to affect somewhere between 2 and 4 million people in the United States alone in its primary form, meaning with no other autoimmune disease attached. It's underdiagnosed, not genuinely rare, and those are two very different things that get confused constantly. Myth: only older women get this, so if that's not me, I can rule it out. Reality: it's true that Sjögren's disproportionately affects women, at roughly a 9-to-1 ratio, and typically first appears between ages 45 and 55. But typically isn't exclusively. Men get it. Younger adults get it. It's simply less common outside that demographic window, which unfortunately also means it gets suspected less often outside that window too, a bias that can genuinely delay diagnosis for anyone who doesn't fit the textbook picture. Myth: if a lip biopsy comes back negative once, that settles it forever. Reality: biopsy results reflect a snapshot of gland tissue at the specific moment the sample was taken, from one specific small area. It's a highly informative snapshot, and generally a reliable one, but autoimmune diseases can evolve over time, and in some ambiguous cases doctors do reasonably retest down the line if new symptoms emerge that weren't present at the original biopsy. Myth: dry eyes and dry mouth are basically cosmetic annoyances, not a real medical problem worth all this testing fuss. Reality: untreated, severe dryness can lead to actual corneal damage in the eyes, significant tooth decay and gum disease in the mouth, and, as we're about to get into, can be one thread in a much larger systemic disease with real complications elsewhere in the body. This isn't chapstick and move on territory once it reaches a certain severity. If any one of those myths was something you genuinely believed until 30 seconds ago, type mind blown in the comments. No shame in it, most people believe at least one of these, that's exactly why they're common enough to be worth busting. Let's rapid fire a few questions I already know are loading in your head right now. I've had dry eyes and dry mouth for years and nobody's ever run these specific tests, should I be worried? Not panicked, but it's absolutely worth a direct conversation with a rheumatologist, specifically asking about a Schirmer test, salivary flow testing, an SSA antibody panel, and whether a lip biopsy makes sense for your specific history. The average gap between symptom onset and an actual Sjögren's diagnosis has been measured at somewhere between 4 and 9 years in some studies, which tells you this delay is disturbingly common, not some rare oversight. If I don't have a separate autoimmune disease like scleroderma or lupus, does any of this even apply to me? Completely, yes. Primary Sjögren's, meaning it shows up entirely on its own, with no other autoimmune disease attached, affects an estimated 2 to 4 million people in the US, and about half of all Sjögren's cases are exactly this standalone type. The Sicca versus Sjögren's confusion isn't limited to people with a second diagnosis already in hand. Marcus, from earlier, is a perfect example of exactly this. No scleroderma, no lupus, just standalone primary Sjögren's that took 2 years and a routine physical to finally get named correctly. Is Sjögren's actually rare, or is it just rarely correctly diagnosed? Genuinely more the second one than the first. It disproportionately affects women, roughly 9-to-1 compared to men, typically shows up between ages 45 and 55, and gets tangled up constantly with fibromyalgia, general aging, medication side effects, and plain old dehydration, all of which can also cause dry eyes and dry mouth, muddying the diagnostic water even further. What's actually the single biggest red flag that this is more than just dryness? A new lump or persistent swelling in a salivary gland, especially one-sided swelling near your jaw or ear that doesn't go away, deserves prompt medical attention and often a biopsy, because it's one of the signs tied to that elevated lymphoma risk we mentioned earlier in confirmed Sjögren's patients. That is not a wait-and-see symptom. That's a call your doctor this week symptom. What if my doctor already told me I have Sjögren's, but I never actually got the lip biopsy or the SSA test? Should I ask for them retroactively? Yes, and don't feel awkward about it. A confident-sounding diagnosis and a confirmed diagnosis aren't automatically the same thing, and it's completely reasonable to ask, plainly, which specific tests confirm this, and could we run the ones I haven't had yet? A good doctor won't be offended by that question. If anything, it usually leads to a more precise, more useful treatment plan for everyone involved, including them. Can you have both, some fibrotic gland damage and true Sjögren's, at the same time? Genuinely yes, and this is part of what makes some cases trickier to sort out than the clean Jenna versus Priya split I gave you earlier. Overlap and mixed presentations exist in real medicine far more often than tidy textbook examples suggest, which is exactly why the full diagnostic workup matters so much instead of stopping at the first piece of supporting evidence and calling it done. Is there any at-home test I can do before bothering a doctor with this? Not a reliable one, unfortunately, and I genuinely caution against trusting anything marketed as a home Sjögren's test kit. The tests that actually matter here, the lip biopsy, the antibody panel, the properly administered Schirmer test, require clinical equipment, trained interpretation, and in the biopsy's case, an actual minor procedure. What you can absolutely do at home is track your symptoms clearly, the way we talked about with that 3-point list, so that when you do get to a doctor's office, you're walking in with useful, organized information instead of a vague, "I've just felt dry for a while now." How long does the whole diagnostic process typically take once someone actually starts pursuing it properly? It varies a lot depending on how quickly referrals happen and how backed up rheumatology scheduling is in your area, but once you're actually in front of the right specialist asking the right questions, the core tests themselves, blood work, Schirmer test, and if needed, the lip biopsy, can often be completed within a matter of weeks, not years. The years-long delays we've talked about tend to happen in the gap before someone starts asking the right questions in the first place, which is exactly the gap this video is trying to help close. If I get diagnosed with true Sjögren's, does that mean I'm guaranteed to develop all those extraglandular complications you mentioned? Not even close, and I want to be very direct about that. Research consistently shows that severe extraglandular, multi-organ involvement affects a minority of confirmed Sjögren's patients, commonly cited around 15% for the more serious systemic complications. Most people with confirmed Sjögren's manage the glandular symptoms and fatigue without ever developing major organ involvement. Getting the correct diagnosis is about being properly monitored, not about being handed a guaranteed worst-case outcome. If any of these questions was literally the exact thing you came into this video wondering, type helpful in the comments. That tells me these rapid-fire rounds are actually worth doing again next time. Now, before we get to what to actually, practically do with everything we just covered, I want to slow down for a second on that lymphoma point, because I mentioned it fairly quickly earlier and I don't want it to just fly past as a scary-sounding footnote. Confirmed Sjögren's carries a documented, elevated risk of a specific type of blood cancer called non-Hodgkin lymphoma, most often arising in or near the salivary glands themselves, since that's exactly the tissue under chronic immune assault. Estimates for exactly how elevated that risk is vary depending on the study and how it's measured, but they consistently land well above the general population's baseline risk. That sounds alarming written out plainly like that, so let's immediately add the context that actually matters. The overwhelming majority of people with confirmed Sjögren's never develop lymphoma. This is an elevated risk relative to the general population, not a coin flip, not a countdown clock, and not a certainty. What it actually translates to, practically, is a reason for ongoing monitoring rather than a reason for dread. And here's the genuinely good news buried inside this scarier-sounding fact. When lymphoma does arise in the context of Sjögren's, it's frequently caught at an earlier, more treatable stage specifically because confirmed Sjögren's patients are already being monitored for exactly this. A new lump, a persistent one-sided gland swelling, unexplained weight loss, drenching night sweats. These are the specific things a rheumatologist watching a confirmed Sjögren's patient is trained to take seriously immediately rather than dismiss as just another flare. That vigilance is a direct, practical benefit of having the correct diagnosis on the chart in the first place. It's not a coincidence that patients like Priya, who know they have true Sjögren's, get faster attention for a new swollen gland than someone whose dryness was never formally worked up at all. I bring this up specifically because it circles right back to the entire thesis of this video. The correct label isn't just paperwork. It's the thing that determines whether a lump gets brushed off as probably nothing, or gets a same-week biopsy. It's the thing that determines whether your blood work includes a complement level or doesn't. The stakes of getting this right aren't abstract. They are measured in how fast something serious gets caught, if it ever shows up at all. If that reframed lymphoma risk from scary statistic to reason my doctor is actually watching out for me, type reassured in the comments. Context changes everything, and I wanted you to have the full context, not just the scary headline version. One more thing worth saying clearly, because it's easy for a video like this to accidentally sound like it's only talking to one type of person. Sjögren's is overwhelmingly more common in women, yes, but it is absolutely not exclusively a women's disease. Men get diagnosed with it too, though research suggests it can present slightly differently, and there's some evidence men may be somewhat more likely to develop certain complications like neuropathy when they do have it. Possibly, some researchers suspect, partly because it takes even longer for anyone to consider the diagnosis in a male patient in the first place. Given how strongly the disease gets associated with women in most people's minds, doctors included. Children can develop it too, in a form that doesn't always look identical to the adult presentation, which can make it even harder to recognize early. If you're a man reading dryness symptoms off a list clearly aimed at women in their late 40s, and mentally ruling yourself out, I'd gently push back on that instinct. The disease doesn't check your demographic box before deciding whether to show up. If this is the first time you've heard that Sjögren's isn't just a women's disease, type not just me in the comments. That assumption alone has probably delayed more diagnoses than almost anything else we've covered today. Quick tangent, because it's a fun little piece of trivia that actually reinforces everything we've just spent this whole video on. You may notice some sources calling this Sjögren's syndrome, and others calling it Sjögren's disease. That's not a typo inconsistency between sources. Patient advocacy groups have been pushing to formally shift the terminology from syndrome to disease in recent years, specifically because the word syndrome tends to get casually read as a loose cluster of symptoms rather than a distinct, defined, biologically real disease process, which, ironically, is almost exactly the same category error we've spent this entire video untangling between Sicca and Sjögren's. Language shapes how seriously a condition gets taken, by patients, by doctors, by insurance companies deciding what gets covered. A syndrome can sound vague and squishy. A disease sounds like something with an actual mechanism, actual tests, and actual stakes, which, as we've just spent 40-some minutes proving, it absolutely is. Now, before we close out, let's talk about what to actually do with everything we just covered, because I never want to leave you with a pile of information and no next step. If you currently have unexplained dry eyes or dry mouth, and nobody's ever run the specific tests we talked about, write this down, or better yet, screenshot this part of the video. Ask specifically for a SJÖGREN'S test, a salivary flow measurement, an SSA antibody blood test, and a conversation about whether a lip biopsy is appropriate given your full symptom picture. Those 4 things, together, are what actually separate an educated guess from a confirmed diagnosis. If you already carry a Sjögren's diagnosis, it's worth a quiet, non-alarm check-in with yourself. Do I actually know which specific tests confirm this? If the honest answer is I'm not totally sure, that's a completely reasonable, non-confrontational thing to bring up at your next appointment. You're not questioning your doctor's competence by asking. You're making sure the treatment plan you're on is actually built on the strongest possible foundation. And if you have a connective tissue disease like scleroderma or lupus and you've developed dryness that everyone's been casually attributing to Sjögren's without ever formally testing for it, this is genuinely worth a dedicated conversation, given what we now know about how often that assumption turns out to be wrong in exactly this population. Here's the takeaway I want you leaving with, because it's simpler than the whole detective show journey we just went on. Dryness is a symptom, not a diagnosis, and treating it like a diagnosis is exactly the mix-up doctors are trying to correct right now. If you've been told, casually, in passing, oh yeah, that's probably your Sjögren's without ever actually getting the SJÖGREN'S test, the saliva flow test, the SSA antibody panel, or a lip biopsy, that's worth a follow-up conversation, not because something is necessarily wrong, but because the correct label genuinely changes the correct treatment plan, and you deserve the version of this story built on an actual diagnosis, not an educated guess dressed up as one. I want to leave you with a small, practical toolkit, because I think abstract advice like advocate for yourself tends to evaporate the second you're actually sitting in an exam room with 15 minutes on the clock and a dozen things you meant to say. So here's something more concrete. Before your next appointment about dryness, whether you're chasing a first diagnosis, double-checking an old one, or sorting out whether a new symptom belongs to the same disease or something else entirely, write down 3 things ahead of time. 1. Exactly when the dryness started, as precisely as you can remember it, even if that's just sometime last winter rather than an exact date. 2. What specific tests, if any, you've already had, schoma, saliva flow, SSA, lip biopsy, and what the actual results were, not just they said I was dry, but the real numbers or the real report if you can get your hands on it. 3. Any other symptoms, even ones that feel unrelated or embarrassing or too minor to mention, from joint pain to fatigue to that weird tingling in your feet you've been quietly ignoring for months. Bring that list. Read it out loud if you have to. It turns a vague, anxious I don't feel right into a specific, actionable conversation, and specific, actionable conversations are what actually move a diagnosis forward. And here's something I think is genuinely worth saying out loud, because it rarely gets said plainly in videos like this one. It is not annoying, difficult, or demanding to ask your doctor which specific tests confirmed your diagnosis. It is not overstepping to ask for a referral to rheumatology if you've been managing unexplained dryness for years through an eye doctor and a dentist alone. It is not being that patient to bring a written list of questions into an appointment. The entire reason a formal, point-based diagnostic criteria system exists, the one we walked through earlier, is precisely so that dryness stops getting treated as an obvious, self-explanatory complaint and starts getting the actual investigative rigor it deserves. Asking for that rigor isn't difficult. It's exactly what the system was built to support. If you've ever sat in an appointment feeling like you had to fight to be taken seriously about something as small as dry eyes, type strength in the comments right now. I want to see that word show up over and over, because every single one of you who's pushed through that feeling and asked the harder question anyway deserves to know you're not the only one who's been there. I also want to say something to anyone watching this who just realized, partway through, that they might be a Jenna or a Marcus, someone who's been carrying an assumption, correct or incorrect, for months or years without ever getting the full workup behind it. That's not a failure on your part. Medical systems are complicated, appointments are short, referrals take time, and most people reasonably trust the explanation they're given without independently cross-referencing it against a formal diagnostic criteria checklist. Why would you? You're not expected to be your own rheumatologist. Finding out today that there's a more precise answer available isn't a reason to feel behind. It's just information you didn't have before, and now you do, and that's genuinely the whole point of a video like this one. If this helped you understand the difference between I have dry eyes and I have Sjögren's a little better, share it with anyone in your life juggling an autoimmune disease and unexplained dryness, because this exact mix-up is apparently common enough that rheumatologists felt the need to formally flag it, which tells you it's happening to real people. Probably people you actually know. Maybe someone in a support group you're part of. Maybe a family member who's mentioned dry eyes in passing a dozen times without either of you ever connecting it to anything bigger. Send it their way. The 5 minutes it takes to watch this could genuinely be the nudge that gets someone the right test years earlier than they otherwise would have gotten it. And if you want me to go deeper next, the full extraglandular symptom list for confirmed Sjögren's, how lymphoma screening actually works in practice, what a first rheumatology appointment for suspected Sjögren's typically looks like step by step, or a full breakdown of the medication ladder we touched on earlier, tell me in the comments, and that's exactly where we're headed next. This channel exists because of exactly that back and forth, question by question, video by video, and a lot of what ends up on screen here starts as a comment someone left on a video just like this one. One last thing before I let you go. Whatever your dryness turns out to be, Sjögren's, something else entirely, or some combination the textbooks don't have a tidy name for yet, you deserve an actual answer, built on actual evidence, not a shrug and an assumption. That's not too much to ask. That's just what good medicine is supposed to look like. Get the right test. Get the right label. Get the right treatment. I'll see you in the next one.